Happy Friday, everyone. Welcome. For those of you who are, well, all of you are using the email to join, I'm happy to tell you that it's a partial lie. I get to co-discuss with my friend and colleague, who is also one of the big bosses at CP Solvers, as evidenced by his shirt. I liken his view to a CEO on the top floor of a very important building, Youssef. Youssef, let me hand the mic to you to say hello, and then we can introduce everybody else who's part of this session.
Yeah, hi everyone. Yeah, it does feel very important to go discuss with you, Robbie. I'm excited. It's been a minute. I'm Youssef. I work with the CP Solvers team, currently a hospitalist. Excited to discuss today. Mohammed, you want to introduce yourself and tell us where you're calling from? How did you find out about VMR?
Hello, everyone. I am Mohammed Zubaidi. I'm recently graduated medical doctor from Baghdad, Iraq. I know CP Solvers for almost 2 years. It's very exciting learning from all of the minds from all over the world. Very transformative in a way you're looking into the clinical reasoning, and I'm really excited to present a case to you. And this is actually my first time presenting to the CP Solvers.
Yeah, welcome, Mohammed. We're really excited to hear your case. We don't have other members from Iraq, and people who present frequently are asked to join the team. So you are encouraged to be the first.
Yeah, that's a very good opportunity for me. Thank you very much.
Yeah, and are you gonna do your training there? Or are you trying to come to US? What are your plans?
So and my interests are now I'm testing the specialties. I have interest in interventional radiology and also in medicine. So I'm just testing the specialties before pursuing any further movements.
Yeah, absolutely, absolutely. Take your time.
Yeah.
And today, the people helping us with scribing and teaching points, Julia and Bayan. Julia, you want to say a word as well?
Hello everyone, I'm Julia, medical graduate from Brazil, excited for Mohammed's case.
Awesome. And Bayan, I don't know if you're able to unmute as well.
Yeah, hi everyone. Really excited for today's case.
Awesome. Rabih, if you're ready, we can go ahead and start.
Let's do it. Let's do it. Welcome, Mohammed. Very, very excited to get to know you better through your case. And yeah, let's rock and roll. Take it away, my friend.
Yes. Let's start. I have 6 alquats. My case is divided to 6 alquat. The final alquat including the patient diagnosis and the diagnostic test. So let's get started with the patient chief concern. This patient is 23-year-old male, presented to the emergency department with shortness of breath and skin rash. And I will stop here.
Youssef, what do you want to take this one?
Sure. Yeah, I can take this one. And I think hearing this case, we hear about a 23-year-old male, and we hear about shortness of breath and rash. And there are many ways to think about shortness of breath. And one way you can help clarify it better is to hear about the semantic qualifiers that are specific to shortness of breath. So in general, you want to start thinking about, is this shortness of breath at rest? Is this on exertion? Is it actually orthopnea? Or is this like a pleuritic component? And using these semantic qualifiers can help you narrow it down. Another way to think about it is anatomical. You can jump between the lung and the heart. And these are the major organs you want to jump in between. And the vast majority of shortness of breath cases will be lung, heart, vessels in between, while everything else is much more rare. And in general, as I'm hearing this more information, I want to join these together. And a third way to think about it is actually by category of disease. You know how like Rabih always thinks about infection, malignancy, autoimmune, and drug. I usually don't start with that in shortness of breath, although you can. And just thinking about the age of the patient, take someone who tells you they're 23 years old and they're male. So I think by age alone, that would make, for example, the malignancy less likely. And then by gender alone, you can think of like infection more than autoimmune. And it's still very, very broad to even think about any category of disease, but these are the major buckets you can think through. Rabih, what are you thinking?
Sorry about my delay to the. I'm thinking about how systematic your approach to shortness of breath is, how you're able to get so much out of the words, but also about the patient's age and gender. And I think a question on the table for us to analyze is if we take for a moment that these two things are linked, they may not be. If we take them to be linked, I think there's a key clinical reasoning principle here is whenever you have multiple organs involved, you have to ask yourself how the disease is spreading. Is it spreading hematogenously or is it spreading contiguously? Meaning, is this a systemic disease that involves the lungs and the skin, or is this contiguous spread? And so, an example of a systemic disease might be that the patient has disseminated strongyloides with a periumbilical rash called the thumbprint sign, and and the patient has diffuse alveolar hemorrhage from the parasite migrating into the lungs. And you might ask yourself, gosh, how could you possibly connect the lungs and the skin through anything but a systemic disease, given how far apart these organs are? And that would definitely be true if you were trying to connect the brain and the lung or the kidney and the lung, where they're so far from each other that you really have to invoke something systemic. But I'd remind you to think of the lungs as a mucosal surface, and that this may really be a mucocutaneous disease restricted to the surface of the body, and the lungs just happen to be on the inside surface of the body, but readily accessible to the outside world by bronchoscopy and by bugs. So what I'm going to try to figure out, Youssef, as we listen to this together is, of course, localize the shortness of breath in the anatomical patterns that you did and understand the rash better. But I think in parallel, we have to ask ourselves, is this disease spreading to these two organs via the blood or via a propensity for mucocutaneous dissemination? And the latter category may seem more benign because it's not systemic. But if we heard this patient was recently put on Bactrim for a UTI and has a necrotizing skin rash, all of a sudden TN with bronchiolitis becomes a very morbid possibility. So what's the general clinical reasoning principle here is whenever you have multiple organs involved, your mind is going to gravitate towards the blood being the path of spread. But remember, some organs coexist together in a pattern, and here mucocutaneous is still on the table. All right, Mohammed, Mike, back to you.
Amazing discussion, guys. So then the second aliquot, including the patient HPI and past medical history. This patient condition started 5 days before his emergency department admission, when he developed subjective fevers and itchy rash starting on his trunk and soon have spread to his face and all of his extremities. And his skin rash is associated with the pruritus. For these two symptoms, the patient took diclofenac, paracetamol, and antihistamine with minimal relief of his symptoms. 2 days after the start of the rash, the patient developed gradually increasing progressive shortness of breath. That starts when on exertion, then it progressed to be at rest, associated with a dry cough and one episode of scanty hemoptysis. The patient's shortness of breath progressed over the next 2 days. Then the patient was admitted to the emergency department. When the patient was admitted, the patient was hypoxemic on admission, even on oxygen supplementation, associated with progressive labored breathing. And then the patient was admitted to the ICU on the first day of admission. On the second day of hospitalization, the patient becomes progressively hypoxemic with altered mental state. And then the patient was intubated and mechanically ventilated. The patient have unremarkable past medical history and take no medications and have no allergies. Family history of the patient, there is no similar symptoms in the family. As for the vaccination, patient had COVID vaccine, but other vaccination status was unknown. Patient is not a smoker, there is no history of travel, and there is no sexual contacts, and the patient works in a local police force. And that's the end for our second aliquot.
Yusuf, I cannot wait for your analysis. Honestly, I think there's a lot to digest here. Mohammed, I really attendings in the U.S. evaluate their learners by the quality of their presentation. That's what we do. And this is why I really encourage all of you who are joining us to try to practice these presentations, because I'm not going to be evaluating anybody here. I'm here to learn alongside you, but it's a great opportunity for you to practice those skills. And Mohammed, I have to tell you, the way you're telling the story, not just how you're telling it, but also the delivery, that your pace, it's very easy to follow, and you clearly have such a great grasp of medicine for you to skip already to hospital day 2 to tell us what happened. That level shows an understanding of the diagnostic arc that's well beyond fundamentals and frankly very, very, very well developed. So thank you. It's very obvious to see that. And so maybe, Yusuf, I can just summarize what has happened so everybody's on the same page. I'm curious what your analysis is we hear this is a hyperacute syndrome in the last couple of days, building upon an acute syndrome. Patient's been feeling this for days, initially beginning on the surface in the skin, then affecting his thorax, and then ultimately affecting his brain. We don't hear of any vulnerability or exposure the patient has to this disease process, except potentially a vulnerability in the realm of vaccination status. And I think that's the space we're in. I'm really curious what you're thinking, Yusuf.
Yeah, I think, like you said, I think the thing that stands out to me is that this is very hyper acute. Started 5 days ago and then progressed very rapidly. And the other thing that stood out to me was that this is severe. And one thing that I've learned to practice is that when we were listening about Muhammad's presentation, is that not only did this patient progress despite being hospitalized. So we don't hear what happened to this patient, but I can assume that this patient received a certain number of therapies. And I'm layering that on in that, is this part of the illness? So some diseases, for example, let's say leptospirosis, you might start treatment, but they might progress anyway. They might progress to ARDS. So is this like a progression of disease, and is this part of the natural course? That's the first thought. The second thought, are we not covering for this infection, for example, or are we not treating it right now? So let's say there is a zoonotic exposure, or we hear that this patient is a farmer or has exposure to anthrax or any unique exposure, then we might not be necessarily treating the exposure. That's another thing I can think of. The third thing is, are we not giving the right dose to reach this organism? Let's say this patient has meningitis, you might not be giving the right dose to penetrate the CNS to cover for organisms that can hide in the CNS. And the last thing I'm thinking of is this non-infectious. But usually, the first few days, and we're at day 2, you want to think of infections first and that are reversible, and you want to treat those first before you start thinking about other things. And I think I'm still in that zone of, is this infection? And if not, what could we be missing? Is it in the blood vessels? What kind of rapidly progressive exposure could this be? That's where I'm at. I think I want to take a picture of the lungs and the blood vessels that supply the lungs to characterize it better, because that has diagnostic value. Like if we hear lung nodules versus infiltrate, unilateral versus bilateral, that has value. That's for one. I want to look at the rash to describe it, because that can also have diagnostic value. And 3, I want to characterize is there some encephalopathy? Try to characterize it if we can. The patient is now intubated, but do we need to sample the CSF? That's upfront on my mind. That would be a low-hanging fruit. In terms of lack of immunization, how does that change my thinking? I think exposure to some encapsulated organisms, thinking of Neisseria. This patient is in the right age group to consider Neisseria, Haemophilus as well, and strep are up front. Although these organisms will usually be covered by empiric antibiotics. What are you thinking, Rabih?
Oh, I think that's such a superb analysis of trying to inventory each organ, the brain, the lungs, and the reality that this patient's journey is influenced in large part by the fact that he's been hospitalized. And I have very little data. Maybe we'll just take the rash and try to get as much juice out of it as we can. I see, Dylan, you have your video on. What time is it in Singapore right now? Oh, and I lost Youssef. Uh-oh. Am I freezing here? Oh, there we go. Okay, you're good? Okay. Um, yeah, Youssef, I think I can't wait to see the rash for a variety of reasons. But I think if you just go to a very simplistic model of infections, which you prioritize, right? You think acute infections are unusually anything but viral or bacterial. You have subacute fungal infections, subacute parasitic infections. There are some exceptions, of course, but whenever you think an acute infection, you're often thinking, is it a virus or a bacteria? And then very helpful shortcut to take to try to distinguish between those two is viruses tend to be symmetric and bacteria tend to be asymmetric. So bilateral cellulitis doesn't exist, except when I presented it to you all in the rapid fire, and yet another reason you should join the academy. Bilateral interstitial infiltrates, virus, unifocal consolidation, bacteria. So I'd really emphasize that when you're looking at the skin, if you see evidence of focality in one specific part of his skin is involved, you're probably going to lean much more towards a bacterial infection and invoke something like toxic shock syndrome, for example. But we heard, at least based on the verbal description from the patient, that the patient's whole body is affected. And that really is a powerful clue to the presence of a viral process. But because the patient is so sick, it's probably helpful to have a checklist of bacterial infections that can be symmetric. And I think the two main ones are Mycoplasma pneumoniae and toxic shock syndrome, erythroderma from those two. So in this patient, you might ask yourself, should I empirically treat them for mycoplasma and should I empirically treat them for pyogenic organisms that cause toxic shock? And I think they even accidentally would be treated for those two things. So the main question often becomes, are there any viral infections that can do this? And that analysis is a wise one to do, but it's often a disappointing one to do because there are very few empiric antiviral treatments you can render for somebody. The only exception are the herpes viruses. And so if you ask yourself if this rash looks in any way like a herpes infection, very, very low threshold to start IV acyclovir, especially in somebody who may have impaired vaccination status. So this is why this analysis ultimately leads you to a management changing dilemma of like, when would you think to do acyclovir for pneumonia? You might think about it based on this for sure. But just to illustrate the principle that if you think virus, you're usually kind of disappointed because even for COVID and influenza, we talk about treatment, but their efficacy is questionable at best. But the big exception is acyclovir, very, very effective medication. And the other thing that's different between viruses and bacteria, in addition to symmetry versus asymmetry, is risk of healthcare transmission. So if you ask yourself, are there any viruses that can cause an erythrodermic rash that can progress to pneumonia and encephalitis that put you, Youssef, as the treating provider at risk? And the answer is, heck yeah, measles. And so for me, I think that this patient should be on strict airborne and droplet precautions. I think I would have a really, really powerful progress based on the rash as to what mechanism. But as you said, we also have to inventory the lungs radiographically and potentially inventory the brain either through imaging or through CSF. But since we have the skin for free, I think that space is going to really influence our analysis. All right, Mohammed, mic to you, my friend.
Amazing discussion. So let's move on to the third part of our case, including the physical examination. On general examination, the patient was ill-appearing and was confused. Patient was not oriented to time and place, oriented only to person, with a Glasgow Coma scale of 13 out of 15. The patient's vital signs was elevated temperature, 39 Celsius, and heart rate was 115 beats per minute, and the blood pressure was 110 over 70 millimeter mercury, and respiratory rate was 30 cycle per minute. Oxygen saturation was at 86% on oxygen supplementation with non-rebreather mask. Chest examination, the patient using accessory muscles, and he was tachypneic. On auscultation, there is bilateral coarse crackles. Skin examination of the patient, there is diffuse vesicular rash with crusted and uncrusted lesions on the face, chest, and extremities, upper and lower extremities. Cardiac and abdominal examination was normal. Neuro exam was not conducted in terms of motor sensory. I have only the confusion part, but the patient doesn't have any abnormal body movements, and there is no agitation. And I have now a representative image I want to share it with you of the rash. This is not the patient actual rash, but a representative image.
Yeah, thank you, Mohammed. That sounds great. Yeah, feel free to go ahead and share it. It should be good to go.
Can you see the rash?
Yeah, go for it, Youssef. What do you think?
I think we have diffuse vesicles, and I think that significantly narrows our differential diagnosis. And in general, when I'm thinking of diffuse vesicles, I'm thinking about varicella, like chickenpox. You can get that if you get that as an adult. The manifestations tend to be much more severe, and you can have a severe presentation as opposed to getting it when you're younger. I had chickenpox when I was younger, but it was mostly like itching, and it would not progress to severe disease. But the older you get, the more you can get like progressive disease with organ involvement. Herpes viruses as well. Mpox can present like this in the right host. And then the question is, do we need to look for an immunocompromising condition, or is the patient's presentation alone, can they get VZV without being immune compromised? And I think you can get VZV without being immune compromised, and you don't need to have another condition. You don't need an HIV test. You don't need, you don't need to have HIV to get severe VZV, although I would screen for that. So we don't necessarily need to dig very, very deep for an immunocompromising condition, but I would screen for like HIV, for example. This also affects isolation. Like you mentioned, Rabih, if you have more than one dermatome, then you need airborne precautions because it's very, very infectious. You can start treatment as well. You get an ID consult early on. And then in terms of management, I think it's just like supportive care, and you can try some antivirals, I think, but I don't know about the efficacy. What are you thinking, Rabih?
Yeah, I think it's amazing how, Youssef, whenever you have a localized skin problem, it's often very difficult to make progress. But when you have widespread skin disease, the nature of the rash is really evocative. And so here we see a symmetric rash. And so it's amazing how all your thoughts were viral. And then based on the description of the symmetric rash, you were able to make progress. And so I completely agree with you. I think that those are our considerations. And I think you made a very powerful point about how varicella zoster virus can be more severe in adults. And I think if we were to review the two main manifestations of varicella zoster virus, it would be varicella infection, which is the manifestation of your first encounter with that virus. And that virus is so universally present that all of us are likely to encounter it de novo unless we've been vaccinated against it. And so many people his age probably didn't have the opportunity to be vaccinated against it. And so if this were his first time encountering it, he would develop varicella. And the rate of developing symptoms from encountering varicella is very, very high, to the point where many of us have childhood stories like I do, as do you, Yusuf, of getting this infection. And because the infection rate is so high, you definitely don't need an immunocompromising condition. But for most people, it's a febrile disease limited to the skin. But the older you are, the more vulnerable you are for your primary infection to be very, very severe. And that's true not just of VZV, but also HSV, EBV, CMV. Your body tends to not like those viruses for the first time the older you are. If you've acquired it like I have, you can then develop a manifestation called zoster, where you reactivate the virus. and most of the time you reactivate in a local dermatome. But if you do have an immunocompromising condition, you can reactivate and cause disseminated zoster, which is an infectious syndrome that looks nearly identical to primary varicella. So disseminated zoster, reactivation of the disease back to its hectic original form, requires immunocompromise. But presentation initially is limited. So yeah, I'm right there with you. I think that the good news is that for this patient, he might have response to the one antiviral that we know is effective, which is acyclovir. But I think the DDX is not just limited to zoster, it's limited to the herpes viruses and the pox viruses. If you were to tweak this rash a little bit, you might be open to the possibility that it might represent molluscum contagiosum, but that would be a stretch. That possibility would definitely mandate searching for infection. Sometimes also vesicles like this, if not closely analyzed, might truly represent umbilicated nodules. And if somebody has umbilicated nodules, that is often a very differential diagnosis. So you just have to pay attention to the rash not evolving on you. But I think the surface has spoken, and it's spoken actually pretty boldly. So I think this is a time where you have to be careful because the patient's so sick that you can't get too attracted to your hypothesis. So if I saw this patient, honestly, what would happen in my mind, because I'm still drawn to cool diagnoses, is, oh my gosh, this is primary varicella and acyclovir is going to help this person a lot. But now I've made so many mistakes in my career that I would immediately recognize that, okay, I should act upon that, give him acyclovir and the other things. But also calm down, don't get too excited. This patient's really, really sick for you just to get lost in your cool diagnoses, and make sure that we remain meticulous until the gold standard diagnostic test has returned. And me looking at a skin is never a gold standard diagnostic test for sure. I'm not that good. Yeah, any other thoughts to sprinkle in, Youssef, before we hear from Mohammed?
No, I think similar to what you said, we have to unroof a vesicle, and then you sample that, and you can send it for either look at it under a slide or send for PCR, whatever is available. And I think under the pathology, you can see those giant cells, if I remember correctly, or you can send a PCR, whatever is available at your center. You probably are going to start antibiotics anyway. Most patients will get antibiotics if they're this sick to cover for both. And you're going to get an ID consult early on, and then VZV also, like blood vessels, you can get complications related to that, whether the brain or the lungs. So I'll be on high alert watching for that as well. Back to you, Mohammed.
Nice discussion, guys. I have the fourth alquat, including the patient laboratory findings and chest X-ray. The patient hemoglobin is 11.2 gram per deciliter. White VC is 13K with a neutrophilic predominance at 78%, and lymphocyte are 15%. MCV is 95. The platelets are 138K, which is decreased. Creatinine is normal. BUN is normal. Sodium is 129, which is decreased, and potassium is normal, and chloride is normal. The patient random blood sugar was not available, but I think it's normal. Arterial blood gas of the patient, patient pH is 7.29, and partial pressure of oxygen was 74 millimeter mercury, and PaCO2 was 34, and bicarbonate was 19. On the patient FiO2 of 0.6, aka 60%, the PaO2 over FiO2 ratio was 125 millimeter mercury, indicative of moderate hypoxemia. I also have a representative, it is an actual patient scout image of the chest CT. I want to share it with you.
Ouch. All right, I'll take a crack at this, Youssef, since you were brave enough to take the rash. I see, I'll share a learning point, to be honest with you, first before I look at the X-ray, which is I think a lot of us prioritize a systematic view of X-ray when we're teaching. I don't do that. I first share my reflex thoughts, and then I slow down and be systematic. Because if you hand me an EKG that shows ST elevation MI, I'm not going to be like the rate rhythm axis. And the same is true for an X-ray. If you show me a massive pneumothorax, I'm not going to be looking at the bones. And so, sorry, my computer invited me back. On this X-ray, I think we see that there are symmetric bilateral interstitial infiltrates. What I'm intrigued by, and I would have to zoom in closer, is are these truly interstitial or are they nodular? And in some instances, they really look more circumferential than they look linear. And I would be intrigued by that hypothesis because distinguishing ground glass opacities from nodules on a CT, on the full view of the CT, not the scout, would allow you to make a lot of progress, because it is very, very unusual to have widespread nodules in the face of a vesicular rash. But characteristically, as Youssef emphasized, varicella zoster virus has a propensity to affect blood vessels. And because of that propensity, it's one of the very few non-mycobacterial, non-fungal causes of miliary nodules. And those nodules can actually have hemorrhagic conversion and present with the halo sign, mimicking the features of invasive fungal organisms. And so I was intrigued at that because my initial instinct on this X-ray was, oh, this is a viral X-ray, it's interstitial infiltrates. But then, especially if you look at the top right upper lobe, for example, you see more circles. And so I was wondering if this could have a nodular feature. The CT itself, the full view, would be definitive of that. And I think the learning point here is whenever you see nodules that are widespread in the febrile patient, you think automatically that the patient has mycobacterial or fungal. But now you know that zoster may be the exception to that rule. So here I am breaking the rule that I told you I wouldn't break, which is that to try to be meticulous. Meticulously, I suspect this is an nodular interstitial infiltrate that CT would help you definitively distinguish between the two. Yeah, so those are my my reflex thoughts on the imaging. I'm curious what you think of it, Youssef, and then of course the rest of the labs that we discussed.
Nothing to add for the X-ray. The current guidelines want clinicians to give steroids for patients with severe pneumonia, quote unquote, but I wasn't sure if we do that for viral pneumonia, and I just looked it up, and they actually excluded patients with viral pneumonia from those studies. So if this were bacterial, then maybe we would have given steroids as well. But because we have a suspicion that this is maybe viral, then there's no role for steroids there. We think of steroids as like lowering immunity, but they also lower inflammation. So for example, they do have a benefit in COVID pneumonia, right? Even though it is an infection, but it lowers the inflammation, so it can help with the response. I'm not sure if there's any research on VZV or steroids in that area. That would be something I would look up and ask the experts. In terms of the labs, I think they definitely stand out, but nothing actionable or nothing that I would want to treat before treating the infection. Like a leukocytosis is expected, some anemia, some thrombocytopenia. All of these are not severe enough for me to warrant like a tissue sampling. You could screen for like vitamin deficiencies, etc. But I think a suppressed marrow is expected, and a little bit of kidney hypoperfusion maybe causing some hyponatremia is okay, and you expect that. We hear a little bit of acidosis, but not significantly, maybe some metabolic acidosis as well, but again, not significant enough to warrant any change in management. So I think I would try to get a diagnosis, start empiric therapy, and hope for the best. Back to you, Mohammed.
Well, thank you for this discussion. For the fifth alquat, I have other further labs, including liver function test, including elevated AST at 124 units per liter and elevated ALT at 85 units per liter. Also have elevated C-reactive protein at 100 152 milligram per liter, and elevated ferritin. The patient PT, PTT, INR were normal. Also, patient D-dimer were elevated at 1,200 nanogram per milliliter. The patient HIV tests were negative. COVID-19 PCR were negative, and also blood cultures were negative. Also, the patient had bedside echo that was also normal. And also, I want to share with you the chest CT axial image of this patient.
Yusuf, are you watching how strategic Mohammed is being? He's finally sharing the axial image. Ah, so good. All right, you're up, my friend.
I think my reflex reaction is that all these areas that look white are not supposed to be white. So if you look up a regular, if a normal axial CT, the air should be darker areas, while infiltrates should be like whiter. And we see here like diffuse infiltrates bilaterally in all lung fields. I'm not sure if I see nodules, Rabih. I don't know if you see maybe some nodules. I'm not sure. You could label this as ARDS, which is like non-cardiogenic bilateral infiltrates with a low FiO2. So you can label it as ARDS in this case. That would change. How would it change your management? You could also like do things like proning, for example. You could follow ICU protocols for ARDS. It wouldn't necessarily change your like medication management significantly. What would you add, Rabih?
Yeah, I think, Mohammed, if you wouldn't mind pulling it up one more time, I think this CT is amazing. Yeah, go for it. I think it's just a.
Can you see the CT image?
Maybe can you, Yusuf? Can you see it or?
I see now.
Oh, I can see it. I can see it. Okay, perfect. So, Mohammed, maybe because your mouse.
Want the official report?
No, in a moment. Yeah, in a moment. Let me just try to take a crack at it just for practice. But if I wish you could see my mouse, but I think the CT has everything. So there's three main abnormalities of diffuse lung disease that the radiologists track, which is consolidations, ground glass opacities, and nodules for diffuse lung disease. Consolidation is defined as a area of lung tissue that is so socked in that you cannot see the underlying lung. And I think there are quite a few parts where you cannot make the underlying lung at all. Ground glass opacities are a diffuse infiltrate, but is glass, meaning that you can still see the lung underneath it. And I see some of that as well. But if you look very, very carefully, you say, I'll direct you. So right lobe, all the way posteriorly, you see circular areas that are circular areas that are at the level of a consolidation, but they're circular and very, very circumscribed. I see 1, 2, 3, and then surrounding them is a little ground glass opacity. So, Mohammed, do you mind, is your mouse mobile? I don't know if you try to move your mouse real quick. Does it move on the screen? Yeah, so if you wouldn't mind directing it to the right lobe, and then, yeah, perfect. Then you go all the way down, right next to the pleura. A little further down, and yeah, a little further down. Yeah, keep going, and right there. So there you see essentially the thin, the less dense area is ground glass, and the denser is consolidation. So I'm not sure if the radiologist will officially note this. I think I'm prompted by a pretest hypothesis here, but I think the CT shows everything. It definitely shows consolidation, definitely shows ground glass. But then there's areas where the consolidation is particularly rounded, and then surrounding it is ground glass. So a very, very interesting CT. I'm curious what the actual experts thought of it.
The actual report of this CT scan, as we can see, can you see the shared screen? So the radiological report of this reported bilateral diffuse ground glass opacities associated with segmental airspace consolidation that were confluent airspace consolidations, and associated at the lower section bilateral small amount of pleural effusion. but not visible on this image right now. Also, we can see peribronchial cuffing, normal size heart, and we can see this is the ground glass opacities when you can see the vessels underlying, and the white thing, it is consolidation. Also, the radiology report didn't mention a nodule because they mentioned these consolidations are just a continuation of a large segmental airspace consolidation.
Amazing. Thank you so much for that. Youssef, I babbled away about the CT. I'm curious what your updated analysis of the case is. Where do you think we're heading?
I think the biggest thing is the morbidity of this case and how severe the progression was. I think getting some. I think mostly we will do some empiric coverage while we wait as well. I don't know if he's like developing like DAH, for example, or ARDS. I think it's hard to distinguish just from like the CT scan. I think that's something that will be diagnosed on a BAL if that's optional. I think it's easier if the patient is intubated. So you could screen for DAH, and DAH is diffuse alveolar hemorrhage, which could be caused by VZV, as we said, because VZV affects the blood vessels. So the blood vessels may leak, and you may have release of the blood into the lungs. So you get a diffuse alveolar hemorrhage, and you diagnose that on bronchoscopy, and you get serial washings, and you can notice the blood on the serial washings, and that's how you diagnose it as well. That's where I'm at. Any other thoughts you had, Rabih?
Nada. I'm right there with you, my friend.
And Mohammed, is the next adequate revealed diagnosis?
Yes, if you have any, do you want to send for any diagnostic test other than BAL?
I think we were talking about unroofing a lesion, sending it for PCR. I think I want the cheapest test, which is also like history taking. Maybe if we hear about like an exposure, that would, I think, get us an answer very, very quickly. If we know like, hey, I actually have a nephew who had chickenpox last week, I think that would immediately make us even more confident. And then BAL potentially starting therapy, and depending on the starting empiric therapy, and then depending on progression, we may consider a BAL. What would you do, Rabih? Any tips and tricks to get it quicker or get the patient better faster?
Yeah, the good old Zank smear. Remember that, Youssef?
Yeah.
You could do that. Yeah, I think history would be very powerful here. I think the hepatitis is also very interesting and further reinforces the notion of what these herpes viruses can do. Another feature consistent with it. So yeah, I think that the momentum is heading so much towards primary varicella that you really need that test to be negative to start to invoke other hypotheses, none of which are immediately actionable right now. So I would be holding my breath until that came back, and hopefully I don't have to hold it too long. All right, Mohammed, mic to you, my friend.
Just as a reminder, the family history of this patient, there is no sick contact or people with similar illness. There's no also contact with people with rash in the past few days before his symptoms began. So this patient's symptoms of respiratory compromise and also associated with skin rash was ring the bell for an infection for the treating clinicians at the emergency department. And they started treatment immediately, even before pursuing other diagnostic tests. So for the diagnostic test of this case was on the second day of when the patient was intubated on day 2 of hospitalization. They conducted bronchoalveolar lavage of this patient and shows leukocytosis with neutrophilic predominance. And PCR of the endotracheal sample was positive for varicella zoster virus. So giving the patient radiological appearance of bilateral gland glass opacities and consolidations within 1 week of an insult, a pulmonary insult, the patient was diagnosed with ARDS, possibly and secondary to a varicella zoster virus. So the patient was treated with acyclovir from the first day in the emergency department until discharge from the hospital. The patient was intubated from the second day to the sixth day of hospitalization. So that 4 days of endotracheal intubation with a substantial improvement in hypoxemia, and the patient then was extubated. Along with acyclovir, the patient started on a broad spectrum antibiotics, including vancomycin and cefepime, along with IV dexamethasone. Then the patient was extubated and went to the isolation ward for another 5 days, and then was discharged home at day 11 of hospitalization after ambulating on ambient air, and their skin lesions were started to crust over. So this is a case of varicella pneumonia complicated by ARDS. This patient doesn't have any immunodeficiency, have negative past medical history, and also was investigated for HIV and was negative. So varicella zoster can involve patients who have immunocompetency. So I think we searched the cases reported similar to this case, and the most important thing was to start acyclovir early.
Oh my gosh, I cannot believe this is your first time joining VMR and presenting. It's as if you've been here for a long time. But I tend to talk a lot, so I'm going to stop myself and pass the mic to Youssef to hear what his reflections are.
Yeah, I just wanted to say, Mohammed, despite your excellent CT read, I think you should do internal medicine because clearly you love the medicine as well. So thank you for the great case. I'm so glad the patient was actually on room air. I was actually worried about that. And viruses are still, like, despite years of medical progress, we have so many advancements. We don't have treatments for most viruses, and our strongest protection is actually immunization. So that's why we need to get like herd immunity, get everybody immunized to protect us from viral infections. And they carry a lot of morbidity and mortality. A lot of patients get, if like in this case, we heard that the patient did well, but some patients may get disability from this infection. They may get like an oxygen requirement, chronic respiratory failure, and there's a lot of morbidity related to it. So thank you, and I'm glad the patient did well. Julia, I'm going to throw the mic to you for teaching points. And Mohammed, do you have any reflections before Julia gives us the teaching points?
Yeah, the first time I saw this patient was last year in the beginning, I think January this year, when I was conducting my graduation research at the emergency radiology department. So the patient had this chest CT you see right here. And one reflection, and that makes this case unique, is that, as Rabih said, Rabih was talking about the nodules and associated, these consolidation was surrounded by the ground glass opacities. This called inflammatory nodules, which is very characteristic for varicella zoster pneumonia. And this patient have only ground glass opacities and consolidation that are non-specific. So that adds diagnostic uncertainty to this case, as this bilateral infiltrate can occur, as you said, in diffuse alveolar hemorrhage, and also can occur is other non-specific viral pneumonias. So the diagnosis here in this case was based on this vesicular rash and respiratory compromise, supported by molecular testing.
Absolutely superb, Mohammed. I am so grateful for your contribution today and the clarity of that reflection. I just wanted to go back because every time at the end I try to be like, are there any unanswered questions that we posed earlier? And I think one question that is interesting to reflect on, I hand the mic to Julia, is was this a systemic disease or was it a mucocutaneous one? And I think that's up for debate. But if you really study the manifestations of zoster or varicella, it tends to be a mucocutaneous predominant disease. One of the most common manifestations is pneumonia. You might ask yourself, well, what about the neurological elements and the neurotropism of the virus? this patient's confusion, presumably encephalopathy, it might be systemic, but it also might reflect retrograde transmission of the virus through the cutaneous nerves and back into the brain. Hence the manifestation of zoster as it moves back in that pathway. So this is definitely not just a mucocutaneous disease because of the fact that the liver is involved and the brain is involved. But the tropism of the herpes viruses is certainly mucocutaneous, especially HSV and VZV. And so ultimately, I think this is predominantly a mucocutaneous disease, as the vesicles made vesicles inside the lungs. But it wasn't just that. It started to clearly spread systemically to the point where I think that even a VZV PCR in the blood might have been positive in this patient, but certainly probably not as positive as the vesicles in the BAL. But yeah, very, very interesting case, Mohammed. Thank you so much. And I'm very excited for Julia's learning points.
So let's go to this amazing case. So we had this 23-year-old male that presented with shortness of breath and skin rash. And starting with semantic qualifiers of shortness of breath, it's important to know if this is a pleuritic or topnia, paroxysmal nocturnal dyspnea, or if this is something that worsens with exertion. Other than that, the shortness of breath can come from the lungs, heart, or vessels between them. Other than that, gender is important because autoimmune is more common in females and infection in males. And when multiple organs get involved, Rabih mentioned about if this is hematogenously or continuously. For example, strongyloides is spreading to the lungs. Furthermore, lungs is a mucosal surface within the thorax, as the skin is a mucosal surface over the external part of our body. So we could think about some disease can affect both of them. After presenting the HPI, we see that this was a hyperacute syndrome that was affecting the brain, and the patient progressed despite being hospitalized. That goes towards some possible causes, for example, leptospirosis that will progress anyway. Or if this is a disease that is not being treated right now, for example, zoonotic cause, if we are giving the wrong dose or if this is a non-infection cause. Furthermore, the lack of immunizations increase the risk for encapsulated organisms, for example, Neisseria meningitis. Also, we should think about some acute infections because fungal or zoonotic can occur more subacute. So when we are dealing with acute infections, this is usually viral or bacteria. And the difference between them is because viruses tend to be symmetric, for example, having bilateral consolidation, and bacteria tend to be more asymmetric, for example, focal consolidation. Some examples of bacteria in these cases are mycoplasma and toxic shock syndrome. And other than that, bacteria, we have some specific treatment, except herpes that we have the acyclovir. Going to the rash that was presented, this was a vesicular rash that can occur in a lot of viruses. For example, herpes, varicella, EBV, CMV, pox virus, and all of them have increased risk when the patient is immunocompromised. So it's important to check the HIV status. But the lack of immunization, as in this patient, increased risk of varicella because this virus had a high transmissibility. And in this case, it's important to empirically treat with acyclovir. Going to the X-ray that was presented, we could see symmetric bilateral interstitial infiltrates, and Rabih discussed about mycobacteria and fungal causing this pattern in X-ray, but varicella zoster can also cause this pattern. So the like the other image that we had was CT chest that revealed non-cardiogenic bilateral infiltrates. So this all of ground glass opacities and consolidation. And with all of that in mind, Youssef also mentioned about the high morbidity and mortality in this case, so the importance of giving empirical treatment. And in the final, we had the diagnosis of varicella zoster virus, and we see in this case the importance of immunization even in immunocompetent patients because this case represents the high severity when the patient does not have vaccine. So thank you everyone for this amazing case.
Julia, that was unbelievable. Literally every single learning point that we made, you reiterated in a more concise and a way that flowed really nice to the case. Thank you, Julia. Youssef, excuse me. Final word to you, my friend.
Nothing to add other than if anybody wants to present the case, the link is up there, clinicalproblemsolving.com, and you can present any case, and all cases are common. Even if they're common or uncommon, feel free to join us. So hope you all have a wonderful Friday.